Now, what kind of treatment gap does this new label update fill? Obviously, this is a huge patient population. Uh, how much or how useful of a tool is this that's being added to the clinician's armamentarium?
Yeah, that's a great question. And I think it really begs the question, is there an unmet need in the current way we treat hyperkalemia in the dialysis population? And I think part of that is how you define a problem with current management. So one issue is just, are we achieving adequate control of pre-dialysis hyperkalemia? And part of that depends on what level you use as a cutoff. Certainly, if you use cutoffs greater than 6 or 6.5, the incidence of hyperkalemia in the dialysis population is relatively small. And and so some might say that we're doing okay. This is how we've been managing hyperkalemia for decades, by restricting diet and by using a relatively low potassium. But we believe there is substantial unmet need, and I can give you a couple of examples. First of all is diet. Our study did not look, and our label does not at all speak to the ability of Lokelma to enable dietary changes, but restricting potassium in patients on dialysis, though it's standard of care, may not be optimal care. For example, many of the foods that are high in potassium that patients are told to restrict are the very patients that you and I and patients without kidney disease consider an essential part of a healthy diet: vegetables, fruits, many of which have relatively high potassium. And the clinical community and the academic community are very interested in the concept that perhaps by using a drug like Lokelma, that we might be able to safely modify diets in patients with hyperkalemia to allow them to eat relatively healthier diets that may have cardiovascular benefits. A second part of the unmet need, I think, goes back to the dialysis procedure itself. If you follow what happens to the level of potassium during the dialysis procedure, the patient comes into dialysis with a relatively high potassium. Because dialysis is quite efficient in that several-hour treatment, usually a 3 to 4 hour dialysis session, the potassium drops relatively acutely. And almost all patients, if you measure potassium at the end of the dialysis treatment, will have actually a slightly low potassium, or at least borderline low, at the end of the treatment. Plus, they've decreased their potassium level by almost 2 milliequivalents per liter from start to finish. So that's an interesting question: is rapid lowering of potassium over a few hours, is that a safe thing to do? Well, we are learning more and more that actually dialysis patients, have a substantial incidence of arrhythmias. And we also know they have an incidence of sudden cardiac death. And if you look at the periods that are the highest risk, it's very interesting that the period of highest risk for patients is at the end of that. If you think about that 3 day gap over the weekend, the real periods of risk are right before that and also right after that, which begs the question that both the hyperkalemia and the rapid lowering of potassium may not be liked very much by the heart. And so this is just theory at this point, but we are considering whether intervention to, in essence, avoid potassium being a very sawtooth pattern to being a smoother pattern over the course of the week, does that have a positive impact on cardiovascular outcomes? Certainly, that's going to require substantial evidence to show that.
Was there anything else you wanted to add that you think it's important to touch on in regard to the label update?
Yeah, just a little bit on the label. So the label update for Lokelma occurred at the end of April. And so the label update includes the dosing regimen. There's one difference in the label as compared to our studies, and this is a minor one, is the fact that the FDA ultimately decided that the starting dose for dialysis patients could be either 5 grams or 10 grams, depending on the level of potassium. So I think they provided clinicians to have a bit of judgment that if the feeling was they needed more rapid control and didn't want to have to titrate so quickly, if the potassium was over 6.5 or over, that you could start at a 10-gram dose on non-dialysis days, and if it was less than 6.5, you could start at the 5-gram dose. I do want to reiterate, because this is very important for those clinicians that are gaining experience with low-calma, the 3 ways in which the dosing again differs. One is the fact that the drug is not given with an acute loading dose per se. So you're basically starting with a maintenance dose. 2 is, for most patients, the starting maintenance dose is 5 grams a day, unless you have the higher potassium that I mentioned, as compared to non-dialysis patients where the recommended maintenance dose is 10 grams a day. And the last part, of course, is the non-daily dosing. So the only way AstraZeneca has studied low-calma, and the only way in which it is recommended in the label, is to be given as a single dose on non-dialysis days. For dialysis patients, I think it's also, and clinicians, also important to note, while we have no known drug-drug interactions with low-calma, there is a recommendation that the drug be given at least 2 hours separate from phosphate binders, which of course almost all dialysis patients are taking. All that being said, it really doesn't matter during the day when the low-calma is given, so that shouldn't be a logistical problem in terms of giving the drug. Another issue that just came to my mind thinking of dialysis patients, this is an oral therapy. It is a powder, a white crystalline powder that is mixed in water. It is not a solution, it doesn't dissolve, you're mixing a slurry. But the point I wanted to make is the amount of fluid you need to give to take the drug is small. You can mix this in as little as 30 cc's of water and just stir it, and it's basically a suspension. So there should not be an increased fluid intake in relationship to the amount of fluids that these patients are allowed to take, and they're often on fluid restrictions. Another thing about the drug is that its effect is very specific for potassium, so it does not tend to bind other cations, specifically doesn't bind or remove calcium or magnesium. There is another part of this, which is that low-calma binds another cation, which is NH4, or ammonium. And interestingly, ammonium is the cation that the kidney excretes to get rid of acid from the body. And one of the things we've seen, and it's in our label, is that the use of low-calma in the non-dialysis population is associated with increases in serum bicarbonate, which suggests that the drug is in fact increasing acid removal. We're looking at that in the dialysis population as well, but whether or not this additional removal of acid is of clinical benefit to patients is something we still have to evaluate.